Thank you very much for joining us for our first ever virtual Northwest Research Collaborative meeting. Before I go further, I'd just like to take the opportunity to introduce all of the committee who've organised tonight's meeting. Usually we had these meetings in person and we would have had the opportunity to meet you and discuss who we were and which roles we were undertaking. So I'm just going to go through on this slide while I give all of the committee members a chance to turn their cameras on, and then I'll show you all of them. We've got myself, Kat and Jen as the chair and the associate chair. Then we have Corinna and Emily as the secretary and the associate secretary. We've got Ahmed with us as our new webmaster, and one of our course surgical trainee reps is with us tonight. That's Madhu Chowdhury. So I'm just going to turn on the view there, stop sharing my screen. So you should be able to see all of us. So we're going to go through tonight some topics about new presentations, and we'll give you contact details at the end, but all of these people you can see here are all part of the committee. If you happen to work with any of these people or come across them in any other way, you can always approach any of them and ask any of us about how to get involved. The main thing with the collaborative research, it's trainee-led, trainee ideas, trainee projects, and we all need to bump into each other. We can't do that quite as much as possible, so we all need to keep in contact and talk about whichever ideas we've got, and we're always happy to have them brought to a meeting like this to present them to everyone. Right, I'm just going to get rid of all of the trainees there and get the committee there again. Thank you very much for showing your faces. I'm just going to go back to sharing my screen with another slide. So one of the first things that we did as a committee when we took over just around a year ago, we'd organised a meeting to talk about the next step with the Northwest Research Collaborative. We've been so fortunate to be involved up until now with this fantastic group of active trainees supported by consultants, have a number of incredibly successful projects that have come out of this research collaborative. We were keen to organise meetings so that people could get together and present their new ideas and see where we were going next. So back in those days, at the end of 2019, somebody from the NWRC funded the meeting, organised some food. We all met up together in person at Wythenshawe Hospital, and all the lovely people you can see on the right-hand side came along to present those 5 ideas for new projects. Just shortly after we'd done that, and then we took over, all excited about the golden age of collaborative research, all of that pretty much ground to a halt thanks to COVID. We had quite a few adaptations to make, and we saw that quite a few of the studies, collaborative and otherwise, had delayed study starts, had study amendments to meet new COVID criteria. There was a huge amount of uncertainty in the research landscape, but we've all decided that it's not all bad. We can all still meet virtually, so we've changed the forum to meeting via Zoom. Now, we can't see everybody face to face at this point in time, but at least we don't have to have a commute across the deanery to worry about where we can get to. The other thing that we're thinking of doing is to make these meetings regular, where we invite everybody from all different hospitals to propose ideas. And with that in mind, we have this fantastic agenda this evening, where we have, firstly, Professor Kirwan, who, one of the exciting developments in the last year is that we have this official role of the Royal College of Surgeons Professor of Surgical Trials right here in Manchester, in the Manchester Clinical Trials Unit. And Cleona has such a wealth of experience in all aspects of research, and it's part of her role to now support all of the collaborative research and help all of these projects to get off the ground. So Cleona is going to give us a brief talk about how she can support the collaborative projects. Following that, we'll have 5 minutes each from the 5 people presenting these new studies. Behind the scenes, despite the COVID, everyone's still been working really hard, setting these studies up, getting initial protocols together. They're all at different stages, but all of the people here to present these studies today are keen to have involvement from any interested trainees at any level across the deanery, and they'll give you details about how to get into contact with them. During the talks, you can have questions at any point in time, and we will be able to keep track of those as we go along. We won't answer them until we get to the end, but don't think we're ignoring you. As soon as we get to the end, we will then deal with all of those questions at the end and ask any of the presenters if they're the ones that you wanted to speak to. So without any further ado, I will hand over to Cleona to do her talk. If I stop sharing my screen. And There we go. And I think you should be able to share a screen if you wanted to, or go ahead and chat, and I'll get out of your way. Thanks.
Brilliant. Thanks a million, Kat. Can people see me and can they see my slides?
Can see you, can't see your slides.
Right, let's see if I've shared screen. Can you see them now?
Yeah.
Brilliant. The wonders of modern technology. But you haven't got it on slideshow yet, have you?
No.
There.
Yeah, perfect.
Good to go.
Okay, I'm just going to bomb through a bit about me and then a bit about the wonders of collaborative research and how fantastic it is and how you can maximise outputs from collaborative research. So first of all, I'm Prof Kirwan. As Kat brilliantly said, I've been lucky enough to be given the Royal College of Surgeons Chair of Surgical Trials with very much the remit of developing surgical trials in all specialities across the northwest of England. As part of that, I'm also Surgical Trials Director at Manchester Clinical Trials Unit, which means I have great links with methodologists at the trials unit, and so a huge amount of expertise that I can tap into there. My other job is clinician scientist in breast oncology, so I do clinical research and translational research and supervise MDs and PhDs, and then my day job is a consultant oncoplastic breast surgeon. So just to explain the advantages of a research collaborative is that, first of all, you're working as a team of like-minded individuals. You can deliver multi-centre trials that is efficient, recruits large numbers, it's quick. You can do ambitious projects really quickly. It's cheap labour. You're not employing nurses or research assistants to do it, so you can deliver without big grants. You can pull in all levels of trainees, from medical students to consultants. And the advantage of that is if you're doing longer term studies, medical students or house officers that join at the beginning can be seeing it through to the end. And therefore, because of all of these advantages, you can do very original research. But I think it's important when you're talking about collaborative research to really be aware of what studies work well for collaboratives and what don't, because some studies really are big, difficult studies to run that aren't collaborative research, and some are clearly MD and PhD studies and are not collaborative research. So you've got to pick your research question wisely for it to be appropriate to collaboratives and so that you can deliver. So the first thing that's brilliant for collaborative research is very common events where you can get a broad-based snapshot audit of a condition. So that means you can do a study prospectively, recruit large numbers of patients across numerous hospitals in a very short amount of time. And the advantage of that is you get to explore the differences between patients, different surgical techniques, and different management of patients. So it allows you to identify areas of practice variability that may result in apparent differences in outcomes. We've got to be clear about the limitations of these audits, because a lot of collaborative research is these type of audits, and limitations are that they're actually hypothesis generating. They're not true evidence, because you can't control for selection bias. There are hidden confounders and there will be interaction effects, but you still get high quality data that you may not be able to get in any other way. So examples of this would be the National Appendicectomy Audit in 2012 that was only recruiting for 2 months and recruited over 3,000 patients and got all of these publications. Another example is the IBRA study, where recruitment went at is demonstrated in the purple bars, and this was at twice the pace of the anticipated recruitment and led to a Lancet publication, so very high impact publications. The IBRA-2 study, the follow-on from this, they cleverly published their protocol and then published their main paper in British Journal of Cancer. So, you know, several high impact publications. Another example of research studies that do well for collaboratives is simple interventional randomized controlled trials. So examples of these, well, the first one, which was the West Mids Collaborative, is the Rossini trial, where they randomized to using a wound guard protection device or not. And again, recruitment was ahead of schedule, which is unheard of in clinical trials. And they got a BMJ publication, so a high impact publication. DREAM's another example of looking at steroids to reduce emesis after major surgery, recruited ahead of schedule, got a BMJ publication. Sunrise is a Northwest Research Collaborative that's actively recruiting at the moment. And another example, well, is the PPAC2 study. Now, this is a good example of a study where the audit was done first. This is a Northwest study, and then that informed the randomized control trial. So this started to be developed in, I think, about 2010-ish, and we've just recruited, completed recruitment to the trial. So you can imagine if you were a house officer joining this, you'd be following it through for a long time. Another example of possible things that could be good for collaborative research is rare events. So an example of this would be angiosarcoma, that is a rare complication of breast radiotherapy. So it's a good way of collecting some data. The challenge of this is these events are so rare that it's hard for people to prospectively collect them, and to retrospectively collect them involves a lot of work. So I'd say this is a more challenging type of study for a collaborative, but still it's the only way you're going to get the answers to these rare events. Systematic reviews can work well as a collaborative if you can split a systematic review up into multiple parts, which is something the breast group did, looking at infection prevention measures in implant surgery, and that led to developing a theatre implant checklist that's used widely across the UK. And then another example of a research collaborative type of study that probably doesn't work well, so learn from our my mistakes, is qualitative research. We've done a big study looking at patient priorities in breast cancer research. Eventually we're delivering, but it was a tough one for a collaborative. So I think my top tips for any collaborative research is pick the research question wisely. It's got to be a research question that is ideally suited to collaborative research. Plan it carefully. And another major top tip, get advice and involve experienced researchers, because big numbers does not equal good experience. You need experience as well as numbers, because there's so many unknown unknowns, so you do need guidance. Build a good team, and if necessary use a trial centre. And as I say, I'm linked into Manchester Clinical Trial Centre as a surgical director, so please speak to me about any research, because if I don't know, I've got a friend who does. And absolutely involve PPI, or patient and public involvement. And to help with that, the Northwest Research Design Service is absolutely fantastic in helping design research studies. Remember to hold your team members accountable, because you're only as good as your weakest link. So if you're waiting on someone to deliver something and they can't for whatever reason, the study will stall. So it's vital that you've got backup to prevent that. And therefore set deadlines, because it's easy for things to drift. When there's a big study, you might need to swap the leadership, because studies take a long time. And if someone suddenly goes off sick, or has exams, or goes on a fellowship, they might need to hand over the leadership role. Involve all levels of trainees, and like PPAC, that's a great example of when you might need junior trainees, because they'll be in it for the long haul. Keep it simple, stupid. And communicate, that's a vital one, because when you got multiple team members and things are happening fast, you've got to keep communicating, spotting when it's stalling, bouncing the jobs on, keeping the ball rolling. And one thing that the Northwest Research Collaborative has done brilliantly is define authorship policy up front. So there's a fantastic document that the collaborative did right at the beginning to set the rules for citation for authorships. and you can see how many people can get cited, and so it really does boost your CV. So hopefully learn from the mistakes I've made, because I've made an awful lot of them, but please come and see me with any study for advice, even if it's simply how to access REDCap or a data management system, or stats advice or design advice, and please come and bring them to me. And as I say, if I don't know, hopefully I'll have a friend who does. Thank you. I'm not sure if I'm supposed to ask for questions now, Kat, or not.
I'll save the questions to the end. I'll just see if, bring back, if Eloise is still okay to speak next. Just gonna check. And she just joined us just before we went live. So we could ask, who's next after that? Alex is going to talk about the ARINOSO study. Alex, are you? Oh, Eloise, you're there.
Hi, yeah, I'm here.
Let me spotlight you. There we go. So you're on. I don't know if you had any slides that you needed to share.
Yes, I do. Let me just bring them up now.
Okay.
Can everyone see them?
So not sharing just yet.
Okay. Is it showing now?
No, we can see you, but can't see the slides.
Okay. Let me. And how about now?
Nope. So
No. Sorry.
I think after you hit the green arrow share button, then there's a blue box that appears that says share as well.
right at the bottom where you choose which screen to share, on the bottom right of the box that comes up, there's a blue share.
Okay. Any better?
Not come up yet.
Mm-hmm.
Unless, if it doesn't want to share at the moment, we could ask Alex to do his, and if you wanted to send it to me, I could share yours after Alex has finished, if that's okay?
Yeah, that'd be great. Sorry.
That's okay. If you send yours through to me by email. Alex, are you okay to talk next?
Yeah, let me
let you have a chance to join the spotlight.
see if I can share my screen. Okay. Sorry. I'm also having technical issues. It's wanting to well, I'll tell you what, are you happy if I speak without a presentation? Because it seems that we're both having technical problems.
I'm really glad it worked for Cleaner. I'd think it was my fault. Please, go ahead.
Yeah, hi, good evening everyone. Thanks, Kat. My name's Alex O'Connor, one of the trainees in the region. I did have a PowerPoint presentation put together, and perhaps my ancient Mac might come together in a moment and allow me to share it with you. But it's in regards to a project which we did start last year on the back of the meeting that Kat mentioned in 2019, which seems like such a long time away. Now, about a national audit of patients with bowel ischemia. We have titled it ARINOSO, which stands for Acute Mesenteric Ischemia, a National Observational Study of Presentation Management and Outcomes. Now, the background to this, which I will just go through my slides anyway, maybe you can't see them, is that as all of us know, involved in emergency general surgery on call, it is a significant problem in patients with bowel ischemia. And it's only going to get worse as our patients become older and more comorbid and live for longer. Looking at the most recent NELA publication, the sixth report, which covers data from 2018 to 2019, there was just under 25,000 laparotomies recorded in that NELA report in England and Wales, and 12% of them, so just over 3,000 patients, were recorded as having ischemic bowels. So it's quite a hefty burden of disease. Of those patients, there was a 20% and 24% 30 and 90-day mortality respectively. So almost a quarter of these patients that we're seeing and who are undergoing laparotomy are dying within 90 days of their operation. And actually, it's the second most likely reason to be put on the end-of-life pathway according to the for patients enrolled into NELA, second only to patients with cancer. So that led us to think last year about these patients and their outcomes and the management of these patients. As it stands, whilst there is evidence about how to manage the vascular disease, particularly with regards to the advent of interventional radiology, actually there's very poor quality evidence to support the decision-making perioperatively, be it preoperatively, intraoperatively, or postoperatively. And in particular, we were talking about the rates of resections, anastomoses, stoma formations, the number of patients who go to undergo relook laparotomy, and then following the operation, those patients who die, patients who remain on TPN for a prolonged period of time and suffer with short bowel syndrome. So really what we hope to do as part of the project was to initially undertake a questionnaire aimed predominantly at consultants and senior trainees and to establish the current practice within the UK around these areas of decision making. That was originally planned to be distributed at ACP-GBI last year, but obviously COVID got in the way of that. Following on from that, alongside that, we were hoping to perform a systematic review of the evidence, which would allow us to inform a national snapshot, multi-centre prospective cohort study looking at the presentation management outcomes of patients with bowel ischemia, and that will come in the form of a national audit, similar to what you may have seen with NASBO. So that's where we stand really. As it stands, tailing on from last year, we have partly generated the questionnaire and have the protocol ready to go for the systematic review. But unfortunately, as with most things, a lot stalled over COVID times, and people have moved roles and been redeployed. And so we're hoping to continue that now that hopefully COVID, touch wood, is becoming less of an issue in the coming few months. So I do apologise I couldn't share my slides there, but hopefully that's given everyone a nice overview of where we stand. And I know that Katie's in the room as well. I don't know if she has anything else to add to that. But thanks very much for listening. Yeah.
Yeah, I'm here. Well done, Alex. That was an excellent presentation of where we are so far. So I think we've stalled, unfortunately, over the last year or so. We've made decent progress, haven't we, with the systematic review protocol. And actually, we may actually touch base with Clona and just see whether she's got any contacts within the trial centre, possibly a contact to help with the systematic review. We have got a team pretty well established, haven't we? But if anybody else is interested in getting involved, we would be more than happy to take on
Absolutely.
Some more people. Thank you.
All right, we come back over here. So I've got the presentation that wouldn't work before for Eloise, so I will just load that one up.
Thank you so much, Kat.
No worries. TIGRESS, that's yours, isn't it?
Yes, perfect.
I love the names.
I can't take credit for that, unfortunately.
Oh.
Fab, thank you. So to introduce myself, obviously I'm not very good at Zoom, as you can tell. My name is Eloise Lawrence. I'm an ST1 general surgery run-through trainee in the Northwest. And tonight I'm presenting our TIGRESS study, which is the national audit of the management of groin abscesses. Essentially, we're looking at the management of groin abscesses in both the IVDU and non-IVDU population. Personally working within a busy DGH hospital last year, patients often presented with a suspected groin abscess and were routinely referred to general surgery despite clinical and radiological evidence to suggest different pathology. For example, pseudoaneurysms. Next slide, please. So outcomes in patients presenting with a groin abscess, particularly IVDUs, are currently unknown. The risk of operating on a groin abscess, obviously without accurate imaging, may be catastrophic if the vasculature is involved, requiring immediate specialist input. And so with the centralisation of vascular services, particularly in the Northwest, you know, we don't have vascular services locally in a lot of DGHs, and often, you know, these patients are referred to general surgeons without any vascular service on site to manage the particularly high risk complications. And so delays in management through discussions and transfer to specialist units may overall decrease the risk of adverse patient outcomes, which are currently unknown. And therefore we've designed a multi-centre study in order to review the incidence, the management and outcomes of groin abscesses in the IVDU and non-IVDU population in order to improve patient outcomes. Next slide, please. So these are some of our literature review findings. If you can click on each one of them, Kat, I think it brings up 3 in total. So that's all right, thanks. So prior to this, we undertook a literature review looking at the epidemiology, diagnosis and management of groin abscesses in the UK. So self-reported data is obviously biased, it may be inaccurate, but so far it's recorded 87,000 active IVDUs as of 2011, and this data will be re-audited this year in the UK. No cohort study at present has actually reviewed the incidence or prevalence of groin abscesses specifically, or the incidence of pseudoaneurysms presented as a groin abscess in an IVDU. So for example, in our literature review, we noted in a retrospective study over a 20-year period, 23.6% of pseudoaneurysms, which is a huge number, were misdiagnosed as a groin abscess, which resulted in massive arterial bleeding in incision and drainage. Next slide, please. Yeah. And next, on to the next slide. So the aims of our study are to identify the incidence of acute groin abscesses in both the IVDU and non-IVDU population, as well as looking at the variation in management across all institutions, and particularly between district general hospitals and tertiary sites. Next slide, please. So we are going to evaluate our outcomes primarily through the length of stay. So length of stay is going to be our primary outcome. Secondary outcomes vary in terms of overall incidence of groin abscesses and incidence of pseudoaneurysms presenting as a groin abscess, the time for inter-hospital transfers, as well as 30-day data, including readmission rates and mortality rates. Next slide, please. So again, Kat, sorry, this is another clicky one. So we're going to recruit as many sites as possible in order to collect data over a 3-month period. And ideally, we want to start our study between April and May. So we want to capture attendance and admissions with a groin abscess in patients over the age of 18 with a confirmed groin abscess, either clinically or radiologically. And we will obviously need the help in terms of recruiting these patients from A&E. They may also come in via GP and through hot clinic referrals. We'll follow the outcomes for 30 days, and if possible, all consecutive patients meeting our inclusion criteria should be entered. So we'll obviously collect data on admission information, their clinical presentation, imaging, diagnosis, and decision to treat. And we want to collect all of our data through REDCap, which is essentially why we're coming to you this evening. Next slide, please. So far we've conducted a literature review and a systematic review. We've also designed a protocol for the study, and we want to start contacting sites nationwide in the next couple of months in order to begin our study from April or May. And as Cleona touched on in the last slide, we're going to be actively using social media to try and advertise this, and obviously we'd really appreciate your assistance in terms of collecting data. We want to make this trainee-led, so we want to recruit as many trainees and collaborators nationwide as we can in order to enable our prospective multi-centre study. So ethically, there'll be no interventions made to patient care. It will hopefully be regarded as a service evaluation and won't require any ethical approval or specific patient consent. And we've designed a protocol that will review against HLA framework to be reviewed by a local ethical committee. So that's the end of my presentation. Thank you so much for listening. I understand that questions will be directed at the end, and I don't know if Nick Heywood's around to add anything else that I've not mentioned.
I'll just unmute Nick in case you wanted to add anything.
Hello, can people hear I keep getting a message that my internet connection is unstable, so
You're good for the
can
moment.
you all hear me okay?
Yeah.
Excellent. Right, I'm going to share my screen. You'd be glad to know I've only got one slide, and I'm not going to go through much. So this, I'm going to talk about the DECAF study. Essentially, this is something that we have been looking at probably for the last 3 years in trying to develop. It's been taken to a couple of kind of brainstorming sessions through collaborative things, and it's been backwards and forwards, but essentially through a lot of very useful review from Cleona, which has been extremely helpful to kind of get us back on track, because when you start trying to design a study, you can start quite simple, get overcomplicated, go right the way around in circles and come back exactly to where you were before, and that can take some time. But essentially what we want to look at is decision making and outcomes in colorectal cancer and frailty. There's about 5% of patients that are diagnosed with bowel cancer that have a surgically resectable cancer, but are too frail to go for surgery. We also know that there are probably patients that will fit the frailty group, probably in frailty score 5-6 group, that may end up going for surgery. And those outcomes can be followed up through the Somerset Cancer Registry and the bowel cancer audit, but they're not filtered out for frailty. Then what we also want to look at as well is what is the decision making that happens based on that. We know from the impact audit that was done, which basically sent around a specific case of a cancer patient with the radiology, and quite interestingly, that same case across the country was staged in 15 different ways, depending on TNM staging, which was quite interesting in itself. But that's also telling us that there is also going to be a difference, really, or we hypothesize there'll be a difference really in the way that people assess patients as to whether they're too frail or whether they're okay, but they're frail but will operate on them. So our study wants to take the track of this. We're going to do a site questionnaire with a similar kind of theme to the impact study to give colorectal MDTs around the country a questionnaire with simulated patients to say, how would you assess this patient for theatre and how would you make the decision? Then we're hoping to then do a study that looks at the outcomes based on whether patients are frail or not frail and whether they're operated on or not operated on. Look at those outcomes when it comes to mortality with a whole series of secondary outcomes. Asking a second question which asks, how is that decision making proceeded with? So there are ways in evaluating this from both a clinician and from a patient point of view as to how inclusive people have been made within that, what types of assessments have been made, inputs from geriatricians, whether patients have had CPECs, etc. And then also to then look on later down the line to look at something called decisional regret for these patients that are deemed to be frail, and to see if they've had operations or not had operations, if they have any regret later down the line. So that is essentially the study that we are working on at the moment. We will probably need some help to roll this out. We've got a steering group at the moment, and because I started this as a trainee, and as Cleona alluded to, when people move on through research or whatever, I've stepped out the other end now. I'm now a consultant, and this is trainee-led research, but something that we are, I'm going to stay involved with is getting a couple more people, registrars, involved in this to take this forward. We've highlighted a couple already, but we will probably need some help going forward to roll this study out when it's ready to go. Still a bit of work to go on it at the moment, but that's where we are, and hopefully we'll get methodologists on board, plan to use REDCap for data collection and look at this going forwards. This potentially could lead to other things off the back of it, and hopefully we can get this underway. But it just highlights probably to you people out there that are just embarking on surgery that these kind of things sometimes take quite a bit of time to come to fruition. So I'm not going to take up much more time, but that's essentially where we are at the moment. We've got a study pretty much designed. We have to tweak it a little bit, and then we're hopefully going to look for some funding.
Thank you very much, Nick. You were extremely efficient there. I'd unmuted you and started your video in case you had any comments on the study before, because I know you've been involved in TIGRESS as well, but we've gone straight into DECAF, so that's the first 3 studies done already. We've now got 2 more studies just to speak about. We've got the SPIN study that Jen Kingston's going to talk about, and then lastly the RESOLVE study that Jen Law's going to talk about. So if I'm going to hand over now to Jen Kingston, she can talk to us about the SPIN study.
Hi.
One moment just while I spotlight you for everybody to see. There you go, you're up. And if you want to share your screen, if you've got any slides you want to share.
Thanks. I am going to attempt to share these slides, but it's not a great disaster if I can't. I don't think it's going to let me, unfortunately.
I know that Alex mentioned before his Zoom wouldn't share them because it wanted him to update and authorize his version of Zoom. So.
It's saying it's because it's recording for some reason it's giving me.
Oh, right.
But I think I can pretty much talk you all through anyway at this stage of the study format without too much difficulty. So the SPIN study essentially stands for Surgical Practices in Incisional Hernia Repair. And this was an idea that came to me as moving through the region. I'm sure many of you have shared the same experiences, is that every hospital you go to, you see a wide variation in the types of incisional hernia that are being operated on, also those that aren't operated on, and a huge variation in technique that's used to do that. The main question is, should there be a national database keeping an eye on the types of repair that are being undertaken due to the variation? There's a similar model that's been set up in Denmark, and they can keep an eye on outcomes and results based upon that. As you know, incisional hernia is a really common problem. It's got a significant impact on patient morbidity and mortality. So you look around 20% occurrence of incisional hernia following a midline laparotomy, And if you take that to emergency midline laparotomy and a comorbid patient, incidence is up to 69%. And given there's around 30,000 emergency laparotomies a year, according to NELA in 2018, it's a huge amount of incisional hernias out there, causing a varying amount of impact on patient quality of life. Looking at the data for the NHS in 2017, 2018, there's about 7,500 repairs undertaken on the NHS. And complications are common. Recurrence occurs in up to 40% of incisional hernia repairs, even when you use mesh. You get wound mesh infections, seroma, you can have intra-abdominal injury and enterocutaneous fistula. And certainly these potential complications and mesh use are hugely topical at the moment after the use of vaginal mesh for stress incontinence and organ prolapse. And in fact, the NHS England Mesh Oversight Group report suggested that to be undertaking those procedures, you should have appropriately trained surgeons with up-to-date knowledge of the latest guidance, and you should submit your data to National Audit and Database. So our study design would be to have a multi-centre prospective observational study to report the extent of the variation of practice throughout the UK. We'd want to look at least 1,000 cases and hopefully do this over a 12-month period, which is why everything has come to a standstill, obviously, because COVID, these operations simply aren't being done at the moment. The aim is mainly to assess the variation that you encounter in preoperative workup of the patient, the degree of the defect that's being repaired, the surgical techniques that are being used for the repair, use of adjuncts and prosthesis, and the type of post-operative care that these patients are having in terms of ward-based or high-level care. Importantly, the outcomes of these patients are not the primary goal of this study. It's purely to look at the variations in practice. And we'd like to collect the data with the intention of publication of what we're seeing and the suggestion of, can we be doing anything better? Can we standardise the practice more appropriately? And can we devise a further study to look specifically at the outcomes? So the protocol is pretty much mostly complete. We've had toing and froing about what to include, what not to include, whether to look at outcomes or not. And the consensus so far has been not to, just to get this study up and running and look if we're right, and there's a huge amount of practice variation. We've hit a dead point with ethics being obtained. We did go to our local R&D department, but they're not currently assisting with anything that's not a COVID-related study. Ideally, we're looking for your help on a number of fronts. It's a pretty extensive protocol, which is potentially publishable, which I'd like to go down the route of that, because essentially I don't think we're going to be able to get this started imminently, and it would be a shame for someone else to get there first, or another region to get there first. REDCap also would be an ideal format for collecting the data. We've devised a very simple snapshot on the day data collection tool. There's no follow-up data. Most of them are simply click, tick, yes or no boxes with very few free text answers at all. And collaboration both with yourselves and other regional centres, collaborative groups, to try and make this the national study that it would be really handy to be. And I guess timing of the launch of this is going to be really difficult based on all those factors that we've already mentioned.
Thank you very much, Jen. Let me remove your spotlight. And we've got one final study to talk about this evening. Thank you to the 4 that we've already heard described. If I can ask Jen Law now to put her camera and unmute herself. She's going to do the final talk for the evening, which is about the RESOLVE study. I'll just hand over the full screen to you, Jen. If there's any problems with your slides, I do have a copy of that one, but hopefully that one will work okay.
Can you see that?
Yep.
Cool. Well, I've only got my one slide. So basically, this is much earlier on than it sounds like the other studies are. So we are looking for people that want to be involved, not just in data collection down the line, but also that would like to be involved in other capacities. So basically, we're talking about the RESOLVE study. So a review of sigmoid volvulus management. We're aiming to run it as an international audit of practice. Basically, we've been doing a systematic review, and we found that both the evidence for what to do with patients with sigmoid volvulus and practice throughout the UK and even more worldwide is extremely variable into what to do with these individuals. You know, we all know from on calls that sigmoid volvulus are not uncommon, and it tends to be that they come in, they may get a flatus tube, or they get more commonly they get a decompression endoscopically. They then go home and are forgotten about, hopefully. Sometimes they represent to consecutive on-calls from medical wards being in with other pathologies. So we were keen to discuss about what to do with these patients, but before we do that, we need to know what actually goes on at the moment. Now, from doing our review, we know that most common interventions are, as I say, endoscopic decompression and surgical management in terms of a resection. But obviously, there are other ways in terms of sigmoidopexies, or and whether or not it's better to do an anastomosis at the time of resection, or whether or not it's better to do a Hartmann's procedure. So all of these things we're very keen to find out, and obviously it's generally quite a difficult population because they're usually extremely frail patients. But basically, we'd like to know whether or not we're letting them down, whether or not we should be doing something at their index admission, or whether or not we should be continuing as we are and doing endoscopic decompression. We do have a Twitter account, and if anyone else wants to be involved and you want to email me or tweet us, and that's fine. I think that's it from me, I'm afraid. Nick, if there's anything you wanted to add.
No, I think we're at an early stage, aren't we? We're developing this, and I think the reason we aren't pushing forward too much is a lot to do with COVID, because I suspect that even before COVID, these are a forgotten cohort, and I suspect they're even more so now. And we're hoping to get this set so that when we're starting to come out of things, we can look into it a bit more. I think even if we do something, it's likely to be slightly skewed by the way the world is at the moment. So, but fingers crossed we get this sorted.
Thank you very much. Jan, if you could just stop your screen share for a moment, thank you. Excellent. That is the last of the technological handovers. No, it's the wrong presentation. Thank you to everyone who has come and presented this evening. We've got these 5 fantastic studies, and it's really exciting to hear the different stages that they're all at and all of the ideas that have been involved. I'm just going to share that summary again of which studies we've heard about. So we've got there that list. We've got TIGRESS, ARINOSO, SPIN, DECAF, and RESOLVE. All of them have the potential to be really good collaborative projects that we're going to be hearing about back at meetings like this in a few years' time. And Nick mentioned that these things take a while to come together, and they really do. Finding the one that you find interesting, putting your hand up and saying you want to get involved with that study at whichever stage, now's the time to try and do that. And then in a few years' time, that's when you'll be seeing all of the outputs. Being involved at every stage has been really rewarding. I've got a slide here just about how people can get involved. We've been updating the website with information on the new studies, and thank you to everybody who sent back information as a bit of a summary. We'll be uploading them onto the collaborative website over the next couple of days so that you can follow up on it. We recorded the meeting today as well, so that people who can't make it in person will be emailing the link around to the trainees, so people might watch it later and still want to get in contact. So the study teams are going to provide contact details within those the bits of information that's on the website. The next meeting I've mentioned is due at the beginning of May. We've got 2 more exciting studies to hear about. One I'm really interested to hear about to do with incidental findings on trauma CTs and how they're managed, and another, one of the separate parts of the collaborative is the breast collaborative group, and they're starting another study to do with breast implants. So in joining in with the study, one question I'm just going to come back to everybody who's presented a study today. There are all kinds of different ways that trainees at all levels can get involved, either with writing protocols if they're still at that stage, doing reviews, during the steering committee, looking to lead for specific sites. I'm just going to ask if the leads from each of those studies who've just presented this evening could all unmute themselves and turn their camera back on, and maybe just do a very quick recap on if anyone was going to contact them after this, any of the trainees who either watched this evening or watched the recorded version. What did you anticipate that you're hoping to hear from people that they would want to do? What kind of roles are available for your study? So I'm going to stop my screen share there and then just go back. We've got Eloise there. If any of the other leads from the other studies could unmute and put their videos back on. Eloise, I'm going to start with you because you've been the fastest to respond. If anyone got in contact with you about your study, what kind of roles are you hoping that people get involved in?
So as we've talked about today, we really want to focus on this being a trainee-led study. So in terms of who we've actually got as our steering group, we have fellow core trainees. We've obviously got, you know, Nick as well, and we've also got a medical student. So that's just showing our, you know, kind of breadth in terms of experience. So we would really want trainees from kind of any level who would be willing to participate in terms of being collaborators for their sites. And who were willing to, you know, get involved in obviously the data collection, to include them as collaborators when we eventually come to, you know, publish and kind of detail our findings of our study. So, you know, the fact that we've got kind of trainees at our level as well as, you know, medical students, we can hope to recruit, you know, a lot more junior doctors in terms of getting them in terms of, you know, involving in research and learning how to actually, you know, collect data and such. So that's really what we're hoping to do.
That's brilliant, thank you. We've got Nick and Alex there as well. Nick, I think you were there first. You've probably got your sound on.
First. All right, okay. Yeah, so from where we are, we've got a steering committee. We're hoping to go through for funding and develop this study further. But this kind of study is going to lend itself, hopefully, to getting people involved from an associate PI scheme. So that's something that people might not be aware of, but it allows recognition from the NHR. You are actively involved in research at the centre and recruiting to surgical trials. And we would hope that this would lend itself to whichever hospital you're in, that you will be able to get involved in an associate PI scheme. This is going to be something that's going to need follow-up for a prolonged period of time, maybe a period of year, 18 months. So that means that people are going to be rotating around from one trust to the other. But being part of the associate PI scheme for that study means that you can move from one hospital to the other where you might have been involved in your trust. Then when you move on 6 months later, you can take up that role in the next trust as you move along. So that's where we see that coming in. That might be a year down the line yet. We're going to have to go through funding, sort out the methodology, but that's something to be aware of. And at some point in your training, if you're interested in that, keep an eye out for where things are developing. And when we're ready to look for people for that, we'll bring people on board. So if you're interested, feel free to drop me a line and things like that. So that's where we expect it to go.
I was just going to come to Alex, and we've got a question that's just come in for you there as well for Alex and Katie, which just says, would you be capturing data on non-surgical management of bowel ischemia? And if so, how? And are there any opportunities there to cross over with other disciplines like radiology and geriatrics.
Yeah, thanks very much. So we were interested, sorry I didn't mention that in my presentation, interested in capturing patients who aren't operated, because that's obviously quite a big cohort of patients which we don't know much about. We haven't initially decided to cross over the specialties with radiology and geriatrics as it stands. So yeah, I mean, from our point of view, what we'd really hope for trainees in terms of getting them involved would be to help with the systematic review and the distribution of the questionnaire that we mentioned to consultant surgeons and senior trainees. We've already, as I say, made good inroads in setting that up and starting that, but it's just about pushing that forward in the coming few months, really. So that's where we stand.
Excellent. We've had some, oh yeah, there's another question down here, we'll come up to the one in a moment. Had some positive comments, just really supportive, Jen, of your study as well about the incisional hernias. Huge problem, really good idea to get that all together. And there was one question for Cleona as well. Let me just see if we've done all of the studies. Jen, if I unmute. There we go. If you just quickly summarise what you've been looking for people in your studies, and then we'll pass the last question to Cleona before we finish.
Yeah, no, like I said, it's the early stage and we haven't got ethics or a specific launch date yet. So it's a really good time for people who want to drop me an email to get in touch about the study. We're going to need collaborators at sites. We're going to need people's data collect. We've pretty much got a steering group, so actually myself or Munir or Alex, you can contact any of us to get involved. But there's going to be plenty of different roles and plenty of ways in which to get involved. And I'd say as well, it's a really easy project because it's a simple snapshot. If we can get the red cap up and running of a yes, no, tick box data capture, which would take in the region of about 5 to 10 minutes to do on the day of surgery that the patient comes through. So it's a very easy way to start to get involved. So I look forward to hearing from anyone that wants to drop me a line.
Thank you. The last question that we've got here, it's a really interesting one about sponsorship of any of the studies, NHS trusts versus universities. I know Nick and I have had quite a bit of experience of doing all kinds of different things in the past projects. One of the good things about the collaborative research in the early days was basically anybody who would say yes to helping you, you would work with. So I ended up doing a Northwest Research Collaborative project where the sponsor was actually NHS Greater Glasgow and Clyde, because we just partnered together with another person who was interested and then partnered together with a group of geriatricians. I know with the initial Red Cap access, we were going over to Liverpool at the Surgical Trial Centre of the time and getting it that way. But it's nice now to find that everything is so established that we've got people locally who can champion and provide whatever support that people need. I don't know, Cleona, if you want to just answer that question about your thoughts on who sponsors any of these studies, the local NHS trust versus the university, or whether it just depends on the study type.
I think it probably absolutely does depend on the study type, because sponsorship, which mustn't be confused with funding, sponsorship is about the legal governance for a study. And if the study, and fundamentally the NHS has responsibility for safeguarding for their patients. So if the study largely involves patients or is done on NHS property, then you're probably going to need an NHS sponsor. So that's going to be a named trust that takes legal responsibility for the study. But in terms of how the funding works, that can be shared between university and trust, and where the funding goes in and then can be bounced on, you know, that depends very much on the study design. So it's a very case-by-case thing, and it's the sort of thing that when you're setting up a study, it's good to go and ask around. And don't forget what I said about the research, the Northwest Research Design Service, the NIHR one, which is free. You just send them an email and you get ridiculously helpful advice back and meetings with people. So they're the sort of people who can help with those questions as well. And equally for any of these studies, you know, you can always drop me an email and I can do some hunting around or guide you.
Fantastic. Thank you to everybody who's joined us this evening, and for all of you to come and talk about your studies. I'm feeling optimistic about that roadmap over the next few months, that gradually some of the restrictions should be removed. And for all of these studies that have had frustrations of stopping due to COVID, hopefully all this background work that everyone's been doing, the literature reviews, the getting together, the protocols, it just leaves everyone in a really strong position to get going with enthusiasm when all of the restrictions are eventually lifted. So I'm really looking forward to hearing how these all progress. We'll send out the links afterwards to these studies on the website, to the slides that people have presented and the recording if anybody's missed it. And then our next meeting, as I say, the date's to be confirmed in the first week of May, where we have another 2 new studies looking for people to get involved also. So thank you very much again, everybody, and have a good evening.